Welcome to AETCM, the emergency medicine channel. Today, let us discuss about status epilepticus. We know that epilepsy is a condition where there will be dysynchronized or hypersynchronized neuronal discharge from our electrical discharge from our neuronal system. That produces various types of increased activity, like sometimes it can be muscle activity, sometimes it can be sensory activity or autonomous activity. So various activities can occur due to this hyper synchronized or excessive neuronal discharge. So seizure is a paroxysmal, that means acute, even due to abnormal and excessive. So it is more hyper synchronized discharges, means excessive hyper synchronized discharges from a aggregate of CNS neurons. So increased activity, electrical activity or electrical discharge from one foci of the brain, that produces a seizure. Now we will see what is epilepsy. Epilepsy is a condition which a person has recurrent seizures. If the patient is getting 1 or 2 times seizure, then you can call it as epilepsy. 2 or more unprovoked seizures. So provoked and unprovoked seizures are there. Provoked means in the laboratory conditions you provoke a patient or some triggers may be there. That triggers might have produced a seizure. So if there is an unprovoked 2 or more episodes, then you can call it as recurrent epilepsy. So it's a chronic disease. It will become a chronic disease slowly. Convulsion is a motor. We already told that it can be, the seizure can be motor, sensory, autonomous, like that. Now here the motor component of the seizure is called as convulsion. Like you can see, patient will be having convulsive actions of upper limb, lower limb, face and all. So these are the major differences: seizure, the word meaning you should know, epilepsy and convulsions. Now, status epilepticus means a patient is having continuous seizures more than 5 minutes, or a series of seizures in between patient is not regaining his consciousness. So then also it will become status epilepticus. Whatever it is from the brain, so you can see whenever there is a seizure activity from the brain, there will be continuous hypersynchronized neuronal activity. Now it has become intermittent, but in between the episodes patient's consciousness is completely absent. So that is status epilepticus. Now classification, we can see the classification. One is convulsive status, that is generalized tonic-clonic status, partial or epilepsia partialis continua. Epilepsia partialis continua means epilepsy is there, it's a partial seizure and it will become continuous. That is partial seizures, epilepsia partialis continuous. Non-convulsive status, absent status, complex partial status, neonatal status epilepticus. These are the various classification. We will not be going to the details of various classification. Here we will be more focusing on generalized tonic-clonic seizures or status. Now there are different causes for epilepsy or status epilepsy. Then one of the most important causes non-compliance to the drug. That is the most important cause, or discontinuation of the drug. Alcohol is another major reason for repeated seizures. Both alcohol-induced seizures can be there, or alcohol withdrawal seizures can be there. Acute structural brain damage, that is mostly like in emergency room, mostly we see due to head trauma. That is the most common condition, head trauma. Other than that, brain tumors, metastasis, stroke, subarachnoid hemorrhage, cerebral anoxia, hypoxia, infections like encephalitis, meningitis, abscess, all these things can produce seizures. Metabolic abnormalities, in that hypoglycemia, hyperglycemia both can produce seizures. Then hepatic encephalopathy, uremic encephalopathy, pyridoxine deficiency, hyponatremia, hypomagnesemia, hypocalcemia, all these things can produce seizures. So whenever there is a seizure episode, we have to always see what is the reason for that. We have to investigate for that. Use of or overdose of many recreational drugs or many other drugs also can produce many drugs means especially antibiotics like imipenem, penicillin G, quinolones, metronidazole, INH, all these things. If the patient is having seizure, and the patient can have an aggravation of the seizure due to these drugs. Tricyclic antidepressants and many other recreational drugs also can produce seizures. Now, whenever a patient comes to emergency room with seizure or acute status epilepticus, we have to always check the oxygen, because many patients with seizure, continuous seizure can have hypoxemia. So, ABG has to be taken. In the ABG, you can see many ABGs nowadays we have lactate. Most of the time, that because of continuous motor activity, lactate will be elevated. So, if your ABG machine has got lactate in that, that will give elevated lactates. Okay. Now, blood sugar is very important. Hypoglycemia and hyperglycemia can produce seizure. Continuous seizure can produce hypoglycemia. Electrolyte imbalance, we have already seen hyponatremia, hypernatremia, hypocalcemia, hypercalcemia, hypomagnesemia. Almost all types of electrolyte imbalance can produce seizures. Calcium is very important, sodium is very important, magnesium is very important, phosphorus is very important. So, when you are taking blood, you have to see all these electrolytes. Then liver function test, because hepatic encephalopathy is one important thing, uremic encephalopathy, renal function test, infection screen, especially meningitis, encephalitis, CSF study may be required in patients who is having features of encephalitis or meningitis. The recreational drug screen is very, very important. And one more thing, whenever patient is on anti-epileptic drug, if the patient is already on phenytoin or some drugs, we have to see the drug level. That is very important, because sometimes suboptimal dose can produce seizures. So, anti-epileptic drug, if the patient is already on anti-epileptic, always check whether the patient is having suboptimal dose or optimal dose. So, drug levels are very important. CT brain, MRI brain is very important. EEG also should be done. Sometimes what happens is in ICU, we can see many patients will be unconscious, but if you take an EEG, you can see that there will be seizure activity. So, that is very, very important in emergency room or ICU. Now, management is very important. Whenever we get a patient who is having continuous seizures, clear patient's mouth. A lot of secretions will be there, artificial danger will be there. So, you have to remove that, you have to clear the secretions. So, that these things are very, very important in managing a seizure patient. Administer oxygen only if needed. Many patients can have hypoxemia, so oxygen should be available. Continuous ECG monitoring is very important. BP should be monitored. Some patients can have high BP during seizure episodes. IV line should be IV line access, or IV line should be secured here. Patients who is already like history of alcohol or history of like very emaciated patient, you will have to give thiamine. Thiamine is very important vitamin which can produce Wernicke's encephalopathy, Korsakoff psychosis, all these things. It can also produce seizure also. So, thiamine can be given, and dextrose also can be given in patients who is having hypoglycemia. Now, if the patient seizure episode is over, you have to keep the patient in recovery position, that is left lateral position, that prevents the aspiration. So, that is also very important. Now, left lateral position is a very important position. You can keep the child or adult in left lateral position. Patient will be mostly unconscious. So, it will prevent the aspiration. So, that is a very important step in management of seizure in emergency room. So, immediately once you see the patient who is having seizure, or during seizing episode, if you are seeing the patient, it is always to sedate the brain by giving diazepam, lorazepam, midazolam, like that. But most common drug nowadays we use is lorazepam 0.1 to 1.5 milligram per kg at 1 to 2 minutes interval. So, midazolam, lorazepam is available as IV. You can give that. Midazolam nasal spray is there. Diazepam rectal preparations are there. That also can be tried. So, if the patient improves with that, and if again if one more episode is coming, you can try a repeated dose of lorazepam, or even you can continue the infusion protocol. But midazolam is another important drug in emergency room. We can use it as an infusion protocol, but because that is a very short acting drug, anytime you can stop the infusion. Here normally we give Lorazepam IV dose, 1 or 2 IV doses. If the seizure, like alternatives for midazolam, like Lorazepam, one is IV diazepam. IV diazepam can be given, or rectal diazepam also can be given. Midazolam is another important drug, ultra short acting drug, which can also be used as a continuous infusion. Many ICUs or ERs, we can use midazolam as a continuous infusion. So these are the common drugs which can sedate the brain, and it's a first line treatment in most of the seizures. If the seizure is not getting controlled with the first dose, we can even repeat second dose of midazolam. We can give another dose of another dose of Lorazepam, or midazolam can be given as an infusion, or even diazepam can be given. Diazepam is a long-acting drug. Midazolam is a short-acting drug. Lorazepam is a Lorazepam come in between diazepam and midazolam. Now, if seizure is continuous, even after diazepam or Lorazepam, if it is continuous, you can either go for phosphonatoin or phenytoin. Both the drugs are given in a dose of 20 milligram per kg body weight infusion. So, this phenytoin is a normal drug. This is a prodrug, so phosphonatoin will be acting fast, very fast than phenytoin, and it has got some advantages. It can be given as an IM preparation, IM dose. It can be diluted even dextrosaline, whereas phenytoin should be given as IV. It should be given slowly. It should be diluted in normal saline. These are the major differences between phosphonatoin and phenytoin. Otherwise, both are equal in its action. This can be given very fast. You can give within 30 minutes. But phenytoin should be given very slowly, or 45 to 1 hour, 45 minutes to 1 hour we have to give. If possible, these patients should be monitored with a cardiac monitoring, because rarely these drugs can produce arrhythmias. Now, phenytoin is alternative for phosphonatoin nowadays. It can be diluted only in normal saline, whereas phosphonatoin can be diluted in dextrosaline also, and phosphonatoin can be given as even IM dose. If you are not able to put an IV line, or if you are not getting IV line, you can give the drug as a IM injections. Dose is almost same, 20 milligram per kg body weight. Now, seizure continuing, you can repeat the dose of phenytoin or phosphonatoin. One more dose can be given. But if the patient is already on phenytoin or any other drug, ask for a drug level. That is very important. A patient who is on one or two drugs, if a patient is getting repeated seizures, always ask for a drug level. Next one is sodium valproate. So you can give sodium valproate 20-25 milligram per kg body weight, or levetiracetam can be given. Levetiracetam 40 to 60 milligram per kg body weight can be given as an alternative. Or nowadays we give levetiracetam in many of patients who is having liver disease or any other complication. We depend on levetiracetam. Seizure continuing, you can repeat the dose of phenytoin or lacosamide. That is another drug, IV lacosamide is available, that can be given 200 to 400 milligram IV bolus, and maintenance dose should be started. If seizure again continuously occurring, then phenobarbital is another drug which can be started as 10 milligram per kg body. After the loading dose, start infusion phenobarbital 1 to 4 milligram per kg per hour, and maintain the patient in a seizure-free state. To maintain the patient in a seizure-free state. If the patient does not improve, or patient is having recurrent seizures, either midazolam can be continuously given as an infusion protocol, or you can sedate the patient, or patient with propofol 2 milligram per kg body weight, loading dose followed by 20 to 250 microgram per kg per minute. Other drugs like ketamine can be given. They are all second line drugs. Now, whatever we discussed here is whenever we see a patient with seizure, first line drug is Lorazepam. You can repeat it, phosphonatoin and phenytoin, 20 milligram per kg body weight. Even it continues, you can repeat it. Then phenobarbital again 20 milligram per kg body weight. Then anesthesia with propofol or midazolam infusion will be ideal. So this is the treatment protocol for status epilepticus. We have to always take care of patients' airway, breathing, and circulation. And in fever in eclampsia is a different topic when we are comparing the seizure in a normal person. Here, the treatment of choice will be the delivery of the child is most important, but magnesium sulfate is one of the drugs which can reduce the BP and which can control the seizure in eclampsia. So that should be tried. Now we have discussed about one of the important topic that is status epilepticus. We have drugs like Lorazepam, midazolam, or phenobarbital, phenytoin. Almost all drugs like phenytoin, phosphonatoin, phenobarbital, all these drugs dose will be 20 milligram per kg body weight. And we have to take care of the airway, breathing, circulation, all these things. If the patient's seizure increases with phenytoin and phenobarbital, you have to always suspect porphyria. Thank you.